So hello, I'm Ioanna Athanassaki. I'm a pediatric endocrinologist here in Houston, Texas, through Baylor College of Medicine and Texas Children's Hospital. I am the medical director of clinical operations. I am the thyroid expert for our section and also the endocrine lead for our thyroid tumor board. So the overview of our talk today. So we're going to discuss a little bit about calcium physiology today, and then what considerations somebody has to take into account when managing calcium disorders, and then a few guidelines for the perioperative management of patients undergoing total thyroidectomy, and especially children. But first, we're going to have a little bit of fun. We're going to talk a little bit about the history of the thyroid. So in ancient Greece, they used to diagnose pregnancy through the absence of menses and the tightening of a string around a woman's neck. The Chinese in 1600 BC had recommended that you need to use burnt sponge and seaweed in order to treat goiter and cretinism. Cretinism is a form of hypothyroidism. The anatomic description of the thyroid happened in 1475 by Wang He, who recommended that dried thyroid should be the treatment for goiter. And Sir Thomas Wharton named the gland the thyroid gland. The etymology of the word stems from the Greek shield thyroides, which is shield-like, and you can imagine how that looks a little bit like the thyroid. Now, in the 1820s, they had funny ideas about what the thyroid was. And they used to say the thyroid gland is larger in women because it is necessary to guard the female from the influence of numerous causes of irritation and vexation of mind, of which they're exposed than the male sex. And then, if it were true that the thyroid contains more blood at some times than others, this effect would be visible to the naked eye. In this case, women would certainly have long ceased to go about with bare necks, for husbands would have learned to recognize the swelling of this gland as a danger signal of threatening trouble from their better halves. I'm glad we've come a long way since then. Thyroid diseases were described in 1811, thyroid cancer, 1825, hyperthyroidism, 1871, cretinism, which again is a form of hypothyroidism. And the first thyroid surgery happened in 1st century AD. All right, so why is it important to care about how you're going to perioperative manage a child that's going in for thyroidectomy? It has to do with the anatomy of the thyroid gland and specifically its location. It's very close to many vital organs in the neck. There's a parathyroid right around it and the recurrent laryngeal nerve. So that's why we care so much about thyroidectomy, and that's why we monitor side effects of this surgery. A little bit about calcium physiology. So the calcium is mainly stored in the bones and the body, and only about 1% of calcium is in extracellular fluid. So all our stores are basically in our bones. So what happens when calcium is decreased? What is the normal response to a calcium level dropping? So we have a calcium sensing receptor on our parathyroid that increase the excretion of PTH when that happens. So what does PTH do? PTH will assist in conversion of vitamin D into active form of vitamin D in the kidney. It will also activate vitamin D absorption through the intestines. It will increase calcium resorption from the bones. And it will also increase, when calcium level increases, it will inhibit PTH release to kind of create an equilibrium. what happens with vitamin D? So we have two sources of vitamin D, through the sun and through our diet. And then we activate our vitamin D, which is under PTH control, into 25-hydroxyvitamin D, and then again through 1-alpha hydroxylation in the kidney into the active form of vitamin D, which is calcitriol, or 1,25-dihydroxyvitamin D, and that then exerts action in the bones and the kidneys and many, many other organs. I think if you read any literature, vitamin D has been the culprit of many, many diseases, and also maybe the proponent of their solution. All of that is still to be seen. Now, when you're thinking about calcium disorders, you have to always consider what artifacts can happen when you're measuring a calcium on a patient. And factors that can influence is that if while the blood is drawn, there's prolonged tourniquet application, you will have an increase in your calcium due to your drop in pH. And a prolonged exposure to air will have a decrease in your calcium. Hyperventilation will have a decrease in your calcium, again, due to rise in pH. And then heparin will also increase your calcium by competing with albumin. You have to always consider albumin because most calcium is bound to albumin. So when you have abnormal total calcium levels, you have to also consider, what is my albumin level? And there are ways to correct the calcium, and also ways to measure an ionized calcium, which is unaffected by albumin. You always have to take into consideration of what your PTH level is at the time when you're measuring calcium. And then when you think about how much calcium a patient should be on, it's always about the elemental calcium content of several the formulations that are out there. So why do we care about hypocalcemia? The lower the calcium is, the more severe symptoms you have. You can have paresthesias, you can have spasms, you can have QT prolongation and seizures. We usually never trust an unusual result. We tend to repeat it. We have to use IV calcium for correction wisely but promptly. One of the reasons why we want to avoid IV calcium is because if it extravasates, it can cause significant damage to the surrounding tissues. And then when you're managing calcium disorders, you always have to consider magnesium. Magnesium is necessary for the release of PTH secretion and action. So when you have low magnesium levels, PTH secretion and action is diminished. And hypomagnesemia in itself suppresses parathyroid hormone secretion. Now, indications for thyroidectomy in children are Graves' disease, functioning thyroid nodules, goiter, multinodular goiters that are causing compressions, and of course, cancer. And what we know from the literature is that the complications in children undergoing thyroidectomy are higher when compared to adults. And so in 2016, the American Thyroid Association came out with the recommendation that a high-volume pediatric thyroid surgeon needs to be involved in these cases, and they deemed that that surgeon has to perform at least 30 surgeries or more in order to be competent for these surgeries. Complications of thyroidectomy, as you can see, and in this slide, there are listed complications for benign disease versus cancer. And we can see that the patients with cancer have higher rates of all complications. And the three major ones we think about is transient hypocalcemia, we think about permanent hypoparathyroidism, and then recurrent laryngeal nerve damage. Things that we also track is readmission, infection, and bleeding. And again, here in this slide and this article that was published in 2023, you can see that when they looked at overall complications, benign versus malignant, when the indication was malignancy, the complication rate was higher. And so at Texas Children's, we do perform quite a few thyroid surgeries a year, and we have about a 30% risk of transient hypocalcemia with 10% our patients needing IV calcium, and less than 1% permanent hypoparathyroidism, less than 1% recurrent laryngeal nerve dysfunction. And this is the most recent kind of breakdown in 2023. As you can see, most indications were benign. The work is done by multi-team approach. So we have endocrinology and surgery and oncology, nuclear medicine, pathology, interventional radiology, and then also genetics to assist us. We have a very well outlined thyroidectomy protocol that can be found in our Connect site, and we call it TUMS, which is thyroidectomy without unnecessary medication supplementation. So there are clear guidelines about what needs to happen pre-op, during surgery, and post-op. So pre-op, the most important thing that happens is we evaluate patients for pre-existing calcium conditions. So they get a set of labs for us to evaluate possible vitamin D deficiency or any calcium abnormalities that may have before they go into surgery in order for us to correct it and then safely take them into surgery. On the day of admission, again, the patient will receive immediately post-op calcium and calcitriol, and will receive that throughout their admission at Texas Children's Hospital. Their calcium and PTH is monitored every 6 hours. And based on what that calcium and PTH looks like, and we have recommendations on weight of patient, on how much calcium to give, on what the calcium is and what the calcium start should be. And then post-op, the calcium and calcitriol are weaned either rapidly or slow, depending on what the intra-op PTH was and what the calcium levels post-op were. And we have a coordinator that does all the weaning based on a protocol. Treatment of hypoparathyroidism, the goal is to not normalize the calcium level, but increase it to a level where the patient is no longer symptomatic. Now, one might ask, why not normal range? We want to prevent hypercalciuria, which can cause nephrocalcinosis, nephrolithiasis, and possible chronic kidney disease. So you have to be very careful on how you're replacing calcium and calcitriol in these patients. Again, we want to keep the calcium at the low normal rate, and we frequently monitor calcium, phosphorus, and urine calcium level, as well as renal ultrasound every 2 to 3 years. All right, and I will take questions. Yes, so transient hypocalcemia has been reported in as much as 40 to 50% of children receiving total thyroidectomy. So it's quite common. And, you know, you want to, the reason why we medicate everybody who's coming out of surgery is instead of waiting for the calcium level to drop, we kind of preemptive strike and load them up with it so that they don't get to levels where they need IV calcium. Because if IV calcium extravasates, that can have detrimental effects to the surrounding tissues. Meaning being able to go through puberty, growing appropriately, et cetera. Is that the question? I mean, bone density is always a consideration, right? Just as in adults, but no other major problems. I have to say that if you don't cautiously replace the calcium, the kidneys are at risk because PTH is not there, and calcium gets just dumped into the urine. Yeah. And yes, hypocalcemia is kind of, you know, you get the classic symptoms, but seizures are kind of the main concern. And that's why we want to replace it often, you know, as soon as possible and as aggressively as possible when it happens.
Very low or lack of calcium, do you get where you can't speak and your motor skills?
I mean, you can get something that's called spasms and tetany, where you can't quite control your muscle function. And then you can go into like a full-blown seizure and you're not in control at all. Yes. So basically, the question was long-term effects of hypoparathyroidism in children, if there have been any studies that have identified them. And I'm not aware of any good studies. I have to say that bone density long-term is always a concern for kids and adults. We have not seen any effect on growth and development in children per se that have hypoparathyroidism. And again, the main concern is keeping their calcium level low normal so that their kidneys are not affected. So that was one question. And then the second question was if the calcium level drops, can children kind of not be able to talk? And I talked about muscle spasms and tetany and the possibility of seizures. Thank you so much.